Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Principal, Pigadas Institute of Medical Sciences. This is part of a series of lectures on respiratory system examination. Today, inspection part, inspection of the chest and lower respiratory tract. Here I will be discussing two physical findings. One is the trail sign, second is the crico-sternal distance. How to identify and what are the common reasons for these two findings. The classical method of examination is inspection, palpation, percussion and auscultation, and we divide the respiratory system into upper respiratory tract and lower respiratory tract. So today's main focus is on examination of lower respiratory tract. The major things that should be examined are: first is the position of the trachea. Along with that, look for the position of the apex beat. When the trachea and apex beat are shifted, it means a mediastinal shift. Trachea is central and apex beat is shifted, that is more likely to be a cardiac problem. Then you look for the shape of the chest. Any abnormalities on the surface of the chest like scars, sinuses. Look for dilated veins. Then look at the movements of the chest, including respiratory rate and pattern, and any asymmetry in the movements. Look for intercostal indrawing and examine the spine specifically. These are the major points that we'll be examining during inspection. Now we coming to trachea. The most important thing you should look for is whether the trachea is shifted or not. This is identified by the trail sign. When trachea is shifted to one side, the sternomastoid on that side will become prominent. So here you can see the sternomastoid is prominent on the right side. It is identified by the clavicular head usually. The clavicular head of sternomastoid is prominent to the side where the trachea is shifted. It is because of the attachment of the pretracheal fascia. Inspection and palpation of trachea can be done together. So along with rather than waiting for palpation step, you can examine the trachea now itself. So how will you do? So use your three fingers. The index finger and the ring finger. Index finger and the ring finger is kept like this, and you can see you draw a line with the ring finger, keeping the other two fingers, that is the index and the ring fingers, on the sternoclavicular joint, and see whether the trachea is shifted. And at the end you can alternate way will be to insert your finger to the side of trachea on right side and on the left side, and identify where the space is less. And that is another method for confirming the trachea is shifted. This process should be gentle because this is a little uncomfortable to the patient, so I explained to the patient before doing it. Ensure that the patient's neck muscle is relaxed by bending little. Bend the neck of the patient. That is the chin slightly downwards. And as I have mentioned, dip your index finger into the thorax beside the trachea. Gently apply pressure to locate the border of the trachea. Compare the space on either side of the trachea using the same process. The difference between the spaces will identify the shift of trachea. And this is the trail sign which I already mentioned. The sternomastoid will be prominent on the side to which trachea is shifted. Another important finding you should look for is the crico-sternal distance. That is the distance between the inferior border of the cricoid cartilage and the suprasternal nodes. This is called the crico-sternal distance. In healthy individuals, the distance is around 3 to 4 fingers of the patient. So it depends upon the size of the patient. 3 to 4 fingers of a patient. It is not based on the examiner's finger, it is based on the fingers of the patient. Abnormal cricosternal distance, that is, cricosternal distance is decreased less than 3 fingers, suggests lung is hyperinflated, as in case of asthma or COPD. So here you can see a patient with COPD. The chest is hyperinflated and naturally the cricosternal distance will come down. So that is the importance of looking for the cricosternal distance. In COPD patients, in addition, you may see other findings like use the prominence of the accessory muscles of respiration, the pursed breathing, central cyanosis, and the respiration which is the expiratory phase prolonged. Intercostal indrawing during inspiration can be seen, and the inward movement of the lower ribs on inspiration. And these are the additional findings you may get in patient with hyperinflation of the chest. This also you can look for along with the cricosternal distance. So we have discussed about the trail sign, and the trail sign will be positive when the trachea is pulled, as in collapse or fibrosis, or pushed from opposite side, as in a pleural effusion, pneumothorax, or some cases of mass lesion. And we have discussed about the cricosternal distance. The importance is it is prominent in, or the cricosternal distance will be decreased, that is, it will be less than 3 finger breadth of the patient in case of hyperinflation of the chest, as in COPD and bronchial asthma. One more finding that you may look along with is the tracheal tuck, about which we will discuss in the palpatory session. Thank you.